we'll just say that internally, following the last conversation that we all had, we've heard you in terms of the importance of making sure that the measures that we start collectively tracking and tying to payment for this effort are actionable, that we recognize improvement, that we do not want to create lots of new administrative burden by any means, and that they need to be meaningful. And I'll just highlight that Lauren will be sharing with you some of the results of our discussion on where we feel like multiple conversations have been leading us in terms of some measures that we think make sense to focus on. So thanks for being here again. Look forward to the discussion. And I will either pass it back to Paul or on to Holly.
Yeah, I take it. Yeah. You all set, Paul? Yeah,
I am. Yeah, I also just wanted to point out that Lisa Letourneau is with us today, also with the Department of Clinical Advisor, and I think I saw Bill Monteo as well. If you're visiting or new today, please feel free to just introduce yourself in the chat. With a group this size, we're not gonna spend time. We have too much good discussion to do, so we won't do introductions. And with that, Lauren, I will pass it on to you.
Sure. Okay, so welcome to the third meeting of the NFRCF Innovation and Quality Advisory Council. So today, as Paul and Michelle mentioned, we want to continue that discussion that we started at our previous two meetings regarding quality topics and quality measures. If you weren't able to make the last meeting, the summary I think is pretty detailed and it is posted in the invite. So take a look at it if you weren't here. Just to review, Barbara Bowers presented some of her focus group work with residents of nursing facilities, reminding us of how important it is to find the resident's voice. It was a wonderful presentation. Then Mary Lou described her work with the Moving Forward Coalition regarding Goal 1 of the Moving Forward Coalition, which is person-centered planning. Then we initiated a conversation about clinical measures, for example, the ones that we're now using to sort of assign quality to your work in long-term care, those 5 stars, those awful 5 stars that are publicly available for review at Medicare.gov. So today we'd like to continue this conversation, specifically first exploring resident family satisfaction and experience of care surveys. I know that most of the facilities do indeed do survey their residents for quality and satisfaction, but there's nothing that's reported publicly or to the state. So we have Holly Harmon here. Thank you so much, Holly, who's the Senior Vice President of Quality, Regulatory, and Clinical Services at the American Healthcare Association. Many of you know Holly. She's a Maine resident, and before her role at the American Healthcare Association, she was the Director of Quality Improvement and Regulatory Affairs for the Maine Healthcare Association. Following Holly's presentation, we'll turn it immediately over to Maureen Carland, who's here, who's the present Director of Quality and Regulatory Affairs at the Maine Healthcare Association, and she will fill us in on what's happening in Maine. So with that, there you go, Holly. Thank you.
Thank you so much, Lauren. And it's truly an honor to be here with you all. I'm so excited to see familiar faces and names, and I just appreciate the opportunity to interact with you. I know I'm here briefly, but I'm happy to have further conversation after this call as well. So maybe I'll jump right into the slides if they can be brought up. I'm going to just spend about 15 minutes or so doing a brief overview of particularly, if we go to the next slide, the CAHPS survey and the core Q measures. And I know that I think you've heard from Dr. Nick Castle and Lindsay Schwartz, Dr. Schwartz on this. So I won't go into the technical detail, but I really want to try to give some high-level takeaways of what's the similarities and differences of these two survey options that focus around customer satisfaction or customer experience. Before I go to the next slide to dig into CAHPS, I just want to note that the reason why I'm focusing on these two is because they are two widely known and recognized surveys/measures. I recognize that there are numerous other types of surveys that might exist out there, but would caution proceeding perhaps with the project you're looking at with a survey or measures that are not already standardized or recognized. So that's the reason why I'm focusing on these two. If you go to the next slide, we'll dig into the CAHPS survey, which is Consumer Assessment of Healthcare Providers and Systems Survey, otherwise known as CAHPS. The next slide gives us a bit of background, just to introduce. CAHPS came out of AHRQ, the Agency for Healthcare Research and Quality. It was launched back in 1995 in response, as it shows on the slide, about concerns about good information being available to health plans from enrollees' perspective. It then later got expanded beyond that original focus and has been used in a range of healthcare services. And on the next slide, we'll specifically want to share with you about specific to nursing homes. There are 3 CAHPS surveys specific to nursing homes. They range from the long stay resident survey to a discharged resident survey, as well as a family member survey. Now, I'll note that CAHPS does not have any existing surveys for assisted living. So only nursing homes are the only, in speaking about the populations we're talking about today, I believe, CAHPS only addresses nursing homes. I do want to just note here as well that the long stay resident survey used by CAHPS is designed as an in-person structured interview. It consists of 45 questions that would be asked of long-term care residents living in long-term care. Second, the discharge resident survey is a questionnaire for obvious reasons because it's administered to people after discharge from the skilled nursing facility. That is 50 questions. And then the family member survey similarly is a questionnaire, and that is 51 questions. Each of these, all of these centered around patient experience or family member experience. Okay, next slide. So moving into core Q measures, and we can jump right to the next slide as well. Background there. So core Q is a set of 5 standardized measures for both skilled nursing facilities / nursing facilities and assisted living communities. And it's used specifically to measure satisfaction among patients, residents, and their families. The measure has captures short stay, long stay residents, long stay residents, as well as long stay family data from those surveys for skilled nursing facilities, and then also resident and family data for surveys from assisted living. And on the next slide, if we go to that, so the measures, as I just outlined, it just shows it in a little clearer picture here, the bullets. So there are 5 measures. So that's clear to you how they're divided, which is by the population that is being surveyed. Each of those measures are calculated from 3 to 4 questions. And the first 3 bullets, recommend to others, staff, and care, are the common questions that exist across those 3 to 4 questions for the measures. The addition, the 4th question, is in assisted living. The 4th question is about food. And then in the short stay discharge measure, the 4th question is about discharge needs being met. All right, we'll go to the next slide. So core Q, what really distinguishes core Q at present time is it is a National Quality Forum endorsed measures. So what that means is that core Q has been independently tested as valid and reliable. NQF endorsement is not easily gained. I'm sure many of you well know that NQF endorsement is only gained through extensive testing and evaluation of a measure's reliability and validity. So that's certainly important, and it's important to CMS, and I'll explain that in a moment. But just so you know, all 5 measures of core Q have been endorsed. Specifically, the 3 SNF measures were endorsed back in 2016, and the 2 assisted living core Q measures were endorsed in 2019. Okay, we'll go to the next slide. So now we're going to talk about CAHPS versus core Q. I've kind of thrown a lot of information out at you, and I want to be able to display it a little more clearly. And this is not for the sake of a competing between the two, but for the sake of understanding the similarities and differences. So this table shows you, obviously, the left side is the CAHPS survey features, the right side is the core Q survey features, and then some similarities that are noted across. So just to briefly look at this for a moment. The CAHPS survey measures experience, core Q measures satisfaction. We could probably have an hour discussion about that, but just for sake of communicating the way that each survey expresses the purpose of it. The CAHPS survey uses a 10-point Likert scale, whereas core Q uses a 5-point Likert scale. I'll just jump down. You saw in my presentation earlier, CAPS has extensively more questions than the Core Q survey, 45 or more compared to three to four survey questions, sorry. CAPS generally shows a lower response rate than the Core Q survey, showing a higher response rate. The thought there is the simplicity of the Core Q survey measure helps to increase response rate. And then just, I'll just flip down to say that on the lower part of the table is CMS is no longer pursuing the CAPS survey in long-term care, and the NQF endorsement has lapsed. For Core Q survey, I'll go into a little more detail in a minute. Core Q has been proposed for use in the SNF quality reporting program, and I already mentioned is NQF endorsed. So the next slide, I think, concludes the key information I wanted you to be aware of before we started discussion, which is that in April this year, with the SNF PPS proposed rule, or the payment rule for skilled nursing facilities, CMS did propose to use Core Q, specifically the short stay discharge measure, because that's relevant to the skilled population, beginning January 1st, 2024. And what that means is if that proposal becomes final, of which that rule should be released by August 1st, so we will know in the next week or two, then skilled nursing facilities will be required to submit data for Core Q short stay discharge measure, and that means that certainly skilled nursing facilities across the nation will be headed in that direction, and I think is an important point of information as you think about what Maine wants to put forward, because alignment with existing programs, I think you've all expressed is very important, and we've seen that across the nation. Helping to reduce duplication gives better results generally. So I'm going to pause there. The additional slides are on resources, but I don't want to take more time than on the agenda. And Lauren, I don't know if you'd like me to take questions now, or I think we wait till the discussion.
What do you think, Paul? Should we have Maureen present what's going on in Maine first, and then open up to discussion?
Yeah, why don't we do that? Why don't we go through and have Maureen talk about Maine now, and then we can open it up.
Great, thank you. There you go,
All right.
Maureen.
Hi, thanks everyone. And thank you, Holly, so much. It's always great to have you come, and following in your footsteps is a big set of shoes to follow, and as you all know. So here in Maine, I looked at basically who is using Core Q. So if you'll go to the next slide, please. So right now we have about 87 nursing homes right now, and of them, approximately 50 are using a vendor that has the capacity to report the Core Q measure. So many of you who've been around for a while may remember there was a time when My Interview, which is now NRC, was given out free to a lot of the nursing homes. And so everyone pretty much was using that. I don't know the history behind that. I don't know when that started or ended. Somebody else might know more information on that. It was before my time, I'm afraid. So right now, what we have is a bunch of different surveys being used. Most common one that I'm finding, though, in the state is being used as Pinnacle. And what's nice is Pinnacle can do both assisted living as well as the long-term care. And all of the ones that do the Core Q are available for the Core Q, both for assisted living and for long-term care. So if you look at the next slide. So one of the things is in the residential care, the PNMI, there's really not a requirement on the horizon right now for satisfaction surveys. So you don't find as many of our residential care, assisted living, or PNMIs really doing formal surveys, if you will. Some of the larger organizations do have some. Many of the smaller ones do their satisfaction surveys in-house. Often you find someone has an Excel spreadsheet that they use and they just kind of tabulate it. So they're not really necessarily comparing themselves or benchmarking with anybody. So certainly we have a lot of licensed assisted living residential cares in the state, over 1,000 of them. So we certainly would need to gather more information. I was not able, of course, to reach every single one in the state, but something we'd need to gather more information. Next slide. One of the tools that the majority of the Maine nursing homes in the state are members of Maine Healthcare Association, which gives them access to an online web-based platform called Long-Term Care Trend Tracker. And what is nice about this is a tool that if they are using a vendor for their satisfaction surveys, the vendors can automatically upload into this web-based program so that they can compare themselves against the state and against national levels. Right now, what's interesting is not everybody across the state is uploading into that, but it is something that can happen very easily, especially since most of the homes are using a standardized survey in the nursing home setting. And the next slide, if you would. So basically what happens is a member can go into Long-Term Care Trend Tracker, and if the data has been uploaded by their vendor, they can pull a quality measure report. So they can look at how are they comparing to in their own county, in the entire state, and across the nation. As I said, right now, there's only about 10 to 15 of the homes that are uploading their data. In talking with many of them, they're not quite sure if they just haven't asked their vendors yet to upload it. So they are going to be, I am reaching out with many of them to talk about how can they get their data into Long-Term Care Trend Tracker. And I know that isn't necessarily something that the state has access to, but it would be nice for nursing homes to be able to look at and to be able to compare themselves and have that data right at their fingertips. And they all have access to this. Not quite the same for assisted living yet. If they are a member of National Center for Assisted Living, they certainly would have access to this as well. And we're seeing more and more people are interested in having this data. The measures aren't the same there, as you all know. Those measures come in a different format, but it is a place that people can go and look at the data and benchmark against each other. So kind of in summary, what I would say is that we have about half of our nursing home members currently have access and are using some type of a vendor that has CoreQ. So I think it's something, as we see come January, if this is passed, which we anticipate it to be passed, that it is mandatory to report. It would make sense to have something that people are already doing and using. So just a summary for Maine. Thanks.
Great. You know, we met with, was it Nicholas, who was it? Holly? Castle.
Is it Nick Castle?
Who was the creator of the CoreQ survey. And what he mentioned is that what a lot of people do who use it, a lot of facilities use it, you can add questions after it, right? So if you like particular questions in CAPS, you can add that after. Is that something that's done frequently?
You know, that absolutely, that's right. So the CoreQ measures itself only requires those 3 to 4 questions, but it does not in any way restrict the adding additional questions to the survey. And most often providers do exactly that. You know, vendors are able to support facilities in acting, because while those 3 to 4 questions are all that evidence demonstrates is necessary to provide a valid and reliable measure on customer satisfaction, facilities likely want to know more or drill down further on some other areas of care or services.
Just most of the vendors that our Maine communities are using do have a set of standardized questions along with the CoreQ questions, and then with questions that they want specifically.
I have, I think, a very quick clarifying question for either Holly or Maureen. When you say CoreQ also has an assisted living component, how is assisted living defined? Because as you may or may not know, Holly, that this particular project is looking at NIFs and PNMIC, which is a type of very medically oriented residential care. Would that fit that definition? Or, when I think of assisted living, I think of as an apartment with a door that locks, et cetera.
Yes, absolutely. Yes, assisted living is very broadly defined, and because of the variation that exists across the country. But absolutely, the PNMI facilities in Maine across the board would be inclusive in assisted living.
Thank you.
you know, in the current assisted living. I should
Yeah,
say.
and it would be appropriate to use that Core Q assisted living module in res care in Maine is what I'm hearing you say.
Yes, and
Absolutely.
having,
Yeah, sorry. Maureen.
I have used that, Paul, in the PNMIs that I've been in. There's definitely has used the Core Q as well.
There's a question.
Should have
in
said
the
that.
chat. Yeah.
Yeah.
Barbara, did you want to ask your question?
Sure. The reference to additional questions, and I think you even said standardized, does that mean there's a pool of questions that people can pick from? So they're not all kind of adding their own, or?
So for the Core Q measures, those 3 to 4 questions are standardized. As far as any additional questions, vendors typically have common questions that are utilized. Those are available for facilities to pick from according to their needs. On the CAP side, you know, of course, those 45 to 50 questions are set and standardized in the use of the CAP survey.
Depending on the vendor, you could get different questions. I was just trying to think about the consistency across organizations, because as you said earlier, it's really helpful to be able to compare with the same questions.
Yes, and you know, thank you, Barbara, because it's a great question. Just to dig into that a little more, the fascinating and frankly exciting thing about what Core Q, the research behind Core Q showed, was that you don't have to ask more than those 3 to 4 questions to have a reliable and valid measure for customer satisfaction. So the exciting thing, you know, the work on Core Q, the efforts that Dr. Nick Castle led with AHCA and Cal support back in 2013 or so, shortly before I came to AHCA. It was so exciting. I found as a nurse, as an administrator, as you know, as a person who cares about quality, that we could simplify, you know, this process of hearing the resident's voice on their satisfaction and the family's voice as well. So frankly, 3 or 4 questions. So that, just to help explain, Barbara, to what you're asking, I think that really is the focus, and it's exciting that you can narrow the focus there.
Yep. Ruta, you have a question? Did you want to share that with us?
Yeah, I had several actually. Hi, Holly. I wanted to know about proxy responses. Like, are the resident responses, are they truly resident responses, or may proxies respond on their behalf? And if so, who's a valid proxy? That was my first question. I actually have 3 questions.
Yeah, sure. So, hi, Ruta, good to see you. So there is, I don't actually have it top of my head, but I believe BIMS 7 or less would, the resident survey would not be indicated for use unless there's other, you know, reason why that the facility knows for that person. But the family member survey would continue to be utilized for every resident, if that helps answer where you're going on that.
Yes and no. I mean, so when you report resident response, it is truly residents, like not a mix of residents and proxies.
Correct. That is my understanding, and I can verify that, Ruta. I don't
Yeah,
have the
just 'cause-
specifications in front.
Yeah,
Yeah.
research
Yeah,
indicates
let me
that
verify.
family is not always consistent with resident perspective.
Yes, I do know there's guidance on the BIMS use. Now, as I say this, part of why I'm hesitating is I got a CMS just released those specifications, the draft specifications for the measure. Frankly, that short stay discharge though. So let me verify on the long stay resident, and I can follow up with the group.
Great. And then my other question was, who actually administers the surveys to the residents?
Yes, so it is through the vendor relationship where there is facilities handle that differently, you know, according to, and Maureen, I don't know if you want to speak about that anymore from your direct experience as far as what works best in a facility.
Usually the vendor has often does it via phone calls. In that way, the vendor is able to determine whether or not the resident and or the family member wants to be anonymous, if they have other comments that they want to add. So normally the vendor will reach out to whoever is deemed the appropriate person. So for someone maybe who did have severe dementia, it might be a family member, and to figure out hopefully the person that has been deemed by the resident to speak on their behalf. And often they will call those people directly so that they can have a conversation, a verbal dialogue with the person, which they seem to get, I think, better results. I have found the vendors that I've worked with actually record those, so that if there was ever a question, that there is somebody who could look into it to make sure that things are being asked properly and appropriately. So that's been my experience.
Okay, thanks.
Is there a
Right.
family core Q survey? Did you mention that? There is, isn't there? Yeah.
That is correct. Yeah, for both long-term care residents and as well as for assisted living families.
Great. Jake, did you have a question?
I had just put into the chat that when we add, it's typically a fairly standard addition of questions that really touch on all components of operations, from process related questions about the admission process, the discharge process, the move-in, to day-to-day life of the dining, laundry, therapy, if they feel safe in our environment, as well as obviously care is obviously a big component to it all. So we really tried to touch on the whole continuum of the care and service that folks receive when they're in homes like ours.
Thank you. Any other questions or comments?
Looks like Rich has his hand up.
Go ahead.
Thank you. I had a question. I'm assuming this is all payer sources are eligible to receive the survey. Is there a difference between traditional Medicare A and managed Medicare responses? Is there any data? Because one of the biggest complaints I hear, which is inappropriately directed at the facility, is they discharged me too soon, when the number one reason for people being discharged too soon is that their insurance company stops paying. So I hesitate a little bit because I think that there's some belief that it's the nursing home. The nursing home, unfortunately, gets blamed for a lot of things. The hospital makes a mistake, the nursing home gets blamed. The patient gets discharged too soon because insurance stops, the nursing home gets blamed. So is there any data looking at the different payer sources and how surveys are the survey responses?
Excellent question, Dr. Marino. I do not, I don't know if there is, but I'd like to know the answer myself as well. So I made a note, and I'll follow up and explore that. Certainly, we may, if there isn't, their data may more reveal itself if CMS does finalize this proposed measure and Core Q, short stay discharge, gets more widely used. But I will follow up on that and talk with our research team and get back with you.
That's great. Thank you. I mean, I think it's important to kind of understand this, because managed Medicare is becoming more and more of the market share in a lot of these skilled stays, and we're not going to change that. But how do we try to accommodate for that, and how do we script that, and how do we maybe provide resources better to the facilities to understand how that is? And some of this also may be, how do we help families through an appeal better? And I think some facilities do this a lot better than others. Unfortunately, a lot of insurance companies have actually removed the provider to provider, peer to peer discussion on these things, and it's now purely up to families to appeal some of these decisions. So I think when the families that I see that are most upset is they don't understand they could stay, maybe access Med B services, but they'd have to pay for room and board, because I think the message frequently is, well, your insurance stopped, you have to go home.
Holly,
No,
I believe there is some movement at CMS looking at some of the differences in services provided by managed care versus traditional Medicare Part A. Is that correct?
Yeah, there is on various levels. I need to look into whether at the level of customer satisfaction, but absolutely. And Dr. Marino, I'm sure the group, everything you're saying, I fully recognize, and there's widespread concern about. So appreciate you bringing it up.
Thank you. No, we love Med A patients. The managed Medicare, not so much.
Like Kathy has a question.
Yes, hi, Catherine McGuire. And I came in a little late, so apologies for that. And this may have been addressed at the beginning, but following a little bit on Richard's question by payer, I'm wondering if how this works for long stay residents, and if in fact you can make that distinction in your data, long versus short. And yeah, so just any comment on that. Thanks.
Thank you for asking. Yes, so there are distinct measures for the core queue. I think we're specifically talking about core queue now for short stay patients, residents, short stay discharge it's called, for long stay residents, for long-term care families, for assisted living residents, and then for assisted living families. And the assisted living term is applicable to all of the PMI facilities or res care facilities in Maine. And sorry, so what Dr. Marino, I think I nodded my head, but just to state, every one of the core Q measures, is applicable across all payer sources. There are no distinctions for use. But again, understanding according to the individuals that have various payer sources, and are there impacts on their satisfaction levels in relationship to the type of care they can receive because of their payer source limitations, is an excellent question, and we'll explore that further.
Holly, did you see Mary Lou's question?
Oh, no, sorry.
Whether or not there is any studies involving resident experience with the survey experience itself, phone call and helpers. Do you know if there's any of that?
Another great question. I don't know top of head. I know that part of the it's certainly in the response rate. There's some implied implied experience there, or I should say outcomes as far as having increased participation, for example, with the simplistic questions of the core Q. But we'll look into that further. I love it. It's always, I have a special part of my heart of Maine providers, as you all know, or Maine, I should say, everybody from Maine here. And I often get questions that I don't have answers to when I talk to such talented people. So I love that. So I will follow up on that as well, Mary Lou, and maybe we can chat about that some more.
Can I just say one quick thing to follow up on that? It comes from all this work that I do in ageism, and all that internalized ageism often means that older people just feel like they have to answer a question or a survey, even though in that moment they may feel like they're not valued or respected. So that's where my question comes from.
Totally, and some of the questions you're asking, I think the follow up on Ruta's question, as well as Mary Lou and Dr. Marino's, are also, whatever the answer is today, there's opportunity for continued improvement, right? That's part of what, what hopefully our entire efforts are around this, and how can we continue to make anything we do here most relevant and meaningful to the people we serve. And so I really appreciate you asking it, and we'll follow up. Yes, and Barbara's comment, certainly, satisfaction, higher satisfaction, resident patient satisfaction is associated with better outcomes. So satisfaction matters, and it's very exciting and impressive that the state of Maine and all of you are looking at having this be a part of your future.
I know this was already mentioned, but I do think it's important to think about adding questions, because satisfaction actually doesn't direct you to any kind of improvement. I mean, what do you do with sort of a 4 out of 5? I mean, it doesn't give you any indication of where do you need to go to improve, or even a 2 out of 5. So I just think adding those extra questions, and if it were standardized, it would be ideal.
Yeah, no, appreciate that, Barbara. And I think it depends on the intended use. I think the value of Core Q being such a limited number of questions that is tested and reliable, valid, is from a measurement standpoint, a measurement calculation, it demonstrates its purpose there. That alone, like anything we do, there is not a single point of intervention that gives us the results we want. It's a combination of efforts. And so absolutely, and I would be surprised. I think it's more often like Jake described and Maureen and others that facilities are asking more than those 3 to 4 questions, but for the simplicity of measuring customer satisfaction, we can really be that simple.
And there's some really, really helpful questions on CAHPS, right? I mean, I think, going through the CAHPS, the 45 questions on the long stay CAHPS survey, I mean, I think if you pick some of them, you actually can get to overall quality of life and overall overall experience, right?
Yes, and I assume that everybody would want to balance that with the ease of administration and not making it a 20-question survey, right? So that's the trade-off.
Right.
Exactly.
I think the CAHPS is just so cumbersome because of it needing to be done in person, where the idea that this can be done via phone is really, really open to its usefulness.
I'll just throw out another thought. There's discussion in a different group, that's looking at using Core Q, obviously because of the CMS's future embracing of it that's expected, using Core Q as basically the core measure, and then having, and required reporting, and then having additional optional sharing of information on other areas as part of a collaborative effort that it's an entirely separate group is looking at. And so for the purpose of learning and joint performance improvement, sort of collective performance improvement efforts, learning from each other, that model is being explored, which is I find very intriguing because to Paul's point, I guess, about a balance there it's an interesting balance approach to think about.
Ruda, you have your hand up?
Yeah, thanks. One thing I was wondering, and Holly, I wouldn't expect you to have this off the top of your head, but potentially something you could share with us, what the distribution of the actual data looks like, across facilities nationally and or in Maine, if that's available. Just kind of to Barbara's point, I think that's a really important point, Barbara, that people's rating of their satisfaction is very directly related to what their expectations are. And if they have very low expectations, you might have very high satisfaction, but it's not indicative of truly person-centered quality care. It's indicative of very low expectations. And I think that's important to be cognizant of.
And
Are you speaking, Ruda? Oh, sorry, Maureen.
No, I was going to ask the same question. Are you talking about Core Q data nationally and in the state?
Yeah.
I was going to pull that, but I did not feel at this point there was enough member data uploaded right now. So been reaching out to a few of the homes and trying to help them, if they're using a vendor, to get their vendor to upload the data. Then we would be able to give you the statistics more in Maine. But certainly we have the national. I can send that to send it off to Lauren.
Yeah, I think it'd be great to see sort of what's the distribution like, is there a lot of variation, which again, I think is kind of an important factor in a measure. You want it to differentiate.
Yeah, and if there's a correlation with other quality measures that we're looking at, right? Yeah.
Yes, and just certainly that national look was part of the NQF endorsement exploration, which is very extensive, as I noted before. But I agree with Maureen that if 10 or 11 facilities right now are reporting into the Trend Tracker on Core Q, that would not be perhaps not a representative sample. However, the only other thought is if there were opportunities with a existing, then if Pinnacle is the primary vendor, I think Maureen mentioned, there may be opportunities to explore what the core Q questions measures look like for that for Maine.
Go ahead, Jake.
Just a question, if we could expand on the comments around expectations, and it may be just me misinterpreting the direction there. In my experience, and I can speak for my peers in the industry, expectations when caring for folks' loved ones and what we're providing for services have never been higher on nursing homes, with resources that have never been lower. So just to figure out where we're trying to get with that sort of comment and question, because in my experience, the expectations on nursing homes and the care and services that they provided has never been higher.
Go ahead, Barbara.
Yeah, I just wanted to respond and say, I think that's absolutely true of family members, but I don't think it's true of residents. So
Yeah, I'd say it's both. And I think they're both, you know, and, you know, we serve, you know, folks who are very active still and very with it cognitively. Obviously, there is a strong portion of our population that has, I mean, 70% of folks in nursing homes have dementia. You know, so that sort of statistic then leads itself to folks who may not have the capacity to have appropriate expectations of the care and services that they're receiving. So it's a valid question as to really what is that bar that should be a reasonable bar for folks.
Mhm. Right.
You know what?
Yeah.
Oh, I'm sorry, Holly. I know you need to leave, so I just wanted to
I
give you
do.
an opportunity to say anything in closing.
Okay.
Or
Thank you. Well, I just appreciate the opportunity to speak with you all, and again, have high respect for the work Maine continues to do. And I'll follow up on the questions that were asked, and look for, certainly I'm happy to come back or have other members of my team come back to have further discussion. And I thank you for the time.
yeah, thank you so much.
Thank you, Holly. Really appreciate your time today.
Thank you so much. Take care.
All right, well, that was really helpful. That was really a great conversation. So I think it's time to move on to the next agenda item. Sarah, would you say? Okay.
It's exactly the time. How did we manage that?
Sarah, can you pop up some slides? Great. So as Paul and Michelle mentioned at the beginning, you know, what we're really trying to do is to identify reasonable clinical performance measures to include in a value-based payment methodology. Next slide. The work that we've done internally has been to sort of not just pick, you know, and choose any measure that sounds good, but we've identified a particular set of criteria to evaluate these measures. And I think Michelle touched on these earlier, so I'm not going to go through them in a lot of detail. Obviously, we'd like to find measures that have and applicability in both NF and RCF, although again, there are some differences in patient populations, but as many residents in RCF age in place, you know, they may be easy applicable. We want to pick measures that we identify there is a need for improvement, really not wanting to improve or increase the administrative burden, wanting to see if we can operationalize the measure within resources that are already in place. We want to use vetted measures with comparable benchmarks, and again, not looking to create and vet a new measure. We want to make sure that we have adequate sample sizes, and the measures that we choose need to have significance in terms of cost or quality. They need to be clinically relevant, and they need to be things that are doable, right? I mean, I think if we find measures that you just have no control over, then that's not a good measure. We need to find measures that you actually can identify and through creating new process and create improvements. And it has to reflect a direction that we want to move in. Okay, next slide. So internally, we have had discussions, and you know, where do we start? Certainly, we spent a lot of time looking at Care Compare, looking at the overall staffing and quality long stay stars. We've looked at those individual measures. As most of you know, there are 16 long stay measures in Care Compare. The first 9 are what are used to create the long stay quality measure, or the number of stars under quality long stay. You know, are there measures that Maine performs at above the national average? Are there measures that Maine performs low? And are there measures that maybe we just want to learn more about? So we did a review, and actually I'm going to go right to the next slide. We did a review of this particular document, which was put out in February of 22 by the Center for Health Policy Evaluation and Long-Term Care, which summarized for us 23 states with 30 individual value-based payment programs. And not surprising, many of these programs did indeed use elements of Care Compare. 18 programs in 18 states did use the long stay quality measures. When we looked at them, we found that the top measures used by states as reported in this document were as follows: pressure ulcers, rates of UTIs, antipsychotic use, falls with injuries, and vaccination rates. So that's where we started. Next slide. When we looked at our own data, I think we've presented this before, that you know, 2 claims-based outcomes that Care Compare looks at are ED visits and hospitalizations. It turns out that with regard to hospitalization rate, Maine does not actually do too bad. We actually perform above the national average. But with regard to ED visits, what it looks like is that Maine maybe underperforms a bit, with the national average being 1 visit per 1,000 resident days, compared to what Maine demonstrates, 1.2. ED visits per 1,000 resident days. And we did this work earlier, shared it with you, that even within Maine, there is some variation. The 5-star facilities look to do a little bit better job managing ED visits versus the 1-star facilities. Next. The other measure that we looked at is falls. This is a fall rate with major injury. The national average is 3.4% versus the Maine average 4.1%. Next slide. The rates of urinary tract infections. The national average is 2.3% versus Maine, which is 3.4%. Again, some variation in the 1-star versus 5-star facilities, which we looked at before. Next. Percent residents receiving an antipsychotic medication. The national average is 14%, where the Maine average is 21%. And we've looked at this before as well. Even the 5-star facilities are above the national average. Next. The rates of vaccination is an interesting and I think important process measure. The data doesn't look too bad with regard to vaccinations. Most Maine residents get the vaccinations they need, but are these good performance measures? Again, you look at flu shots, 95.6% in Maine versus the national average, 94.9. Pneumovax, those who need it and received it, 90.5% in Maine versus 92.1% at the national level. So we're just presenting these measures in that we think that they may fulfill some of the criteria that we talked about at the beginning. You know, these are all measures where, at least for the 5, are measures where perhaps we see need for improvement in Maine, or maybe we just don't understand them. Also the vaccination, again, I think it's an important process measure given what we just came out of with regard to COVID. So that's all I have to share with you. I'm wondering what people's thoughts are regarding particular measures that we might think about when integrating into a value-based payment methodology. Paul or Michelle, do you have any comments here?
I think you've covered it well, Lauren. As we look at the star ratings, these are places where Maine seems to be an outlier, so there seems to be a reason to look at them, room for improvement. But, you know, we're looking to you all to give us any feedback that you have on these particular measures. We've also discussed at past meetings concerns about how the star ratings themselves are constructed, but since these are all MDS derived, we don't see that necessarily. We see that as a discussion we can continue to have with you all. Like, you know, Maine could potentially use its MDS data to construct the measure in a different way. There were concerns about the look back period on some of these. There were concerns about using a distribution as opposed to an absolute measure, for example.
Yeah, that's right. I think the question today is, are these good measures? Not how are they going to be
Not how are
managed?
they constructed, right?
Right, right.
Looks like we have lots of comments, Gail.
Hi, good morning, everybody. I just wanted to say a couple of words about the antipsychotic measure. I think it would be important to take a look at the age distribution in your homes. You know, certainly antipsychotics are black box for elders, and we don't want to see people being chemically restrained for dementia behaviors or anything else. But what we're seeing in a lot of the states that we're in is a huge trend toward admitting younger people who do have long histories of severe and persistent mental illness, as well as OUD and AUD, et cetera, for whom many times these medications are appropriate. The facilities that are working with large numbers of these people often have sort of horrific antipsychotic rates, and it's preventing them from participation in preferred networks. It's affecting their 5-star. There's like some downhill unintended consequences, despite the fact that it could be considered that these people are receiving the appropriate treatment for what conditions they have and things that they're dealing with. So just sort of a caveat on that.
Yep, I think that's right. I mean, I think that the way Care Compare reports it, I believe, is sort of excluding those with severe mental health issues that need it, right? Schizophrenia, bipolar. Yep.
No, it's just
So-
the only ones that are excluded are Tourette's, Huntington's, and schizophrenia.
Okay.
Severe bipolar is not, and a lot of these drugs are now being marketed and prescribed for exactly that.
Got it. Yeah. Go ahead,
Yeah,
Rich.
that's absolutely correct. So anybody who has depression with psychotic features, bipolar with psychotic features, psychosis, delusional disorder are all considered not appropriate treatment, even if under the care of a psychiatrist in a nursing home setting.
Barbara.
Yeah, and I know, Maureen, you didn't say that these measures would be necessarily used exclusively, but in my experience, people really tend to default to the clinical indicators and leave out the quality of life measures. And all I'm suggesting is that if a measure like that is used, I think to add something that's really purely quality of life and not a clinical indicator would be really important, because even though people collect the other information, they tend to default to the clinical, the things that are up on Nursing Home Compare. So I just think, just a caveat to be careful that somehow we don't make that look secondary.
Thank you.
And I'll just say we completely agree, and that's partly why we wanted to have the conversation on Core Q today. And we don't have comparative data on patient experience, so Lauren wasn't focusing on that, but I absolutely agree. And when we've been having discussions and looking at what other states are doing, having a range of measures that are clinical as well as structural process related, and looking at a patient experience as well is important.
I think it's also a challenging time to start a new measure, right? I mean, you know, we're not doing, you know, quality of life assessments now. So put that in on day one would be a real challenge. I do wonder if it could be included in one of the add-on questions to Core Q, you know. Go ahead, Ruda.
Yeah, I would just absolutely second Barbara's comment about the importance of measuring quality of life, which may or may not be synonymous with satisfaction. The other thing, just thinking about like the impact of turning these measures into payment incentive driving uses or using them for that purpose, is thinking about, I don't know, I mean, I know you don't want to create new measures, but kind of thinking about whether there are balancing measures to some of them, like, for example, falls with injury. One of the best ways to prevent falls with injury is to keep people as immobile as possible, which is not something we want. But once you incentivize it with a payment incentive, all of a sudden that's a high bar. People are going to want to keep people from falling, which has other negative potential unintended consequences. So thinking about that, and I was thinking the same thing with the antipsychotic measure, and I completely appreciate the comments Gail made regarding younger residents and people with severe and persistent mental illness. That hasn't been adequately accounted for in that measure. And yet, on the side of individuals with dementia who are being really inappropriately treated with antipsychotics for behavioral expressions of communication, thinking about the incentives that have been created just by reporting that measure to use alternative drugs that are really no better than the antipsychotics. So trying to measure things that could be the offsetting or complementary measures to anticipate some of those unintended consequences, I think would be important.
I can't figure out this raising the hand thing, so I'm sorry. But a couple of things that I would also just throw out on that is that we do have a quality measure regarding the use of hypnotics and anxiolytics. So, that could be something that we could look at. So you could look to see is, as Dr. Weierman is saying, if the antipsychotic rate is going down, are those other medication uses going up? The other thing that, and I know it's not a direct correlation with quality of life, but I do think that looking at discharge or back to the community is most people when they enter a skilled rehab or nursing home, majority of people are thinking it would be nice to be able to go back home or to a different level of care. And that is also a measure that is being tracked. So well, I can't say it's necessarily quality of life. I think it does bring a little bit of that, and it is a measure that's already currently being used.
Well, more to come, more discussion to be had, but this is very helpful feedback. Thank you. I think it's time to move on to our last segment.
Karen Lee, are you here? I don't see
I am. Good morning, everybody. I am having some unstable internet, so I'm not going to show my camera, but I am here, and this has been a really interesting, informative conversation. I'm going to try, I'll make up a little bit of time because I want to turn this over to my colleague Rita Oshwick with the Maine CDC to talk about some of what they're doing specific to infection control and looking at nursing homes. So the bottom line is I'm here to talk about a rule that the Maine Health Data Organization, one of the organizations I work with, is responsible for. But before doing that, I wanted to provide some context. Both the Maine Health Data Organization and the Maine Quality Forum, two state agencies, they're independent, that I work with, are required by statute to work together on promoting the transparency of healthcare costs and quality data. And we are also required, the Maine Quality Forum, to produce an annual report that we submit to the Maine State Legislature on the status of healthcare associated infections in Maine. And we do that in collaboration with the Maine CDC. And I wanted to provide that context because one of the things that's really important to the Maine Health Data Organization, which is the entity that defines and collects this data, is that we're not just collecting data for the sake of collecting data. Nobody has time for that. And so the data needs to be used to support different initiatives. And one of the other requirements within our statute is that we make the data that we collect available to the broadest extent possible for people to use it to help improve either healthcare costs in the state of Maine or the quality of healthcare. And so that's just some context behind what I'm going to talk about, which is specifically Rule Chapter 270. And for those of you that are not familiar with government or the way government works, we are required in most cases when there is a law that is passed to develop a rule, which is, you know, another form of regulation that supports the requirements and expands on the requirements within the statute. And so Chapter 2, and we refer to these as rules and chapters. And Chapter 270 is the MHDO's rule that defines healthcare quality data sets and the provisions for submitting those data, the definitions of what the data is, the requirements, the form in which it needs to be submitted, who the data stewards are. So it's a rule that lays out all of the details regarding the requirements. And over the years, and Chapter 270 has been around since 2005. I started working with the organization in this capacity back in 2013. And since I've been with MHDO, and even prior to my time in this role, over the years in collaboration with interested stakeholders, revisions have been made to Chapter 270 to essentially move as the needs changed. So it's really important to me and my board, which is my governance. It's a multi-stakeholder board that, again, we focus on collecting data that will be used to help support different research, policy questions, et cetera, and that we are mindful that there is an administrative burden on those that need to submit the data. And so to the extent that we can leverage existing data repositories, and I'll give you a specific example. Several years ago, we changed our direction from requiring hospitals, and up until just a couple of years ago, Chapter 270 was really all about hospital reporting. And instead of having them report to MHDO and then also report to some other repositories that they were reporting to, like NHSN, the National Healthcare Safety Network, we now have a structure where we have a state rule, and then we collect the data. They can report it through NHSN, and then we go grab the data from NHSN. So they're not reporting it in two places. And we've also tried to streamline so that the state mandate doesn't necessarily differ from a federal mandate. And we use NHSN as the guide for the requirements and what's being reported. So quickly, about, I don't know, Rita, I think it was 2018, 2019, in consultation with the members of our HAI Collaborating Partners Committee, which included representation from all of the hospitals in the state, as well as there were members representing nursing facilities. We had discussions with this group to start thinking about expanding Chapter 270 to bring in nursing facilities. And so we did that, working with that group, and we started with C. diff, and that requirement went into effect in 2020, but with the pandemic, my board made the decision to delay the implementation of that. And so we just met with the nursing facilities a couple of months ago, and we are starting that collection beginning in July of this year. So it was about a 3-year delay. And we are working now on making some additional proposed changes that would focus on, what we talked with the nursing facilities about through that committee was what we really wanted to focus on was data around UTIs. And Rita can talk more about that and why it's different than the reporting that is happening through, I believe its acronym is MDS. There are some significant differences that make the data that we're proposing through NHSN more actionable in terms of actually doing something about the issues that are identified through the reporting. So I know I just have, I think I've hit my 5-minute limit, so I want to turn it over to Rita to provide some of the details. But I would just say this in closing, we are really, as I said, focused on trying to align the data that we're collecting with how different entities that are using this data to drive improvements want to use it, and trying to align those things together, and removing out of Chapter 270 data measures that are no longer, there's no more room for improvement. We used to have a series of data measures that we would collect from the hospitals, and at the end of the day was they had topped out. I mean, there was not any additional improvement that was going to happen. And so we said, you know what, we're going to drop those and we're going to focus on something else. And at that point it was healthcare associated infections. So with that, I will turn it over to Rita that can talk more specifically about what we're thinking about with UTIs.
So very briefly with the UTIs, the MDS data gives us you have X number of UTIs per facility in Maine during such and such a time period. With the NHSN data, we would not only get the actual case counts, we would get the pathogen information, we would get certain signs and symptom information. It helps us target the prevention activities with the facilities to hopefully be able to help them with greater reduction of UTI events. And so that's why we're after the NHSN information, just because all of the criteria behind that UTI is reportable as well. So, and then in general, what my program does with that data is, one, we help the facilities by data cleaning the data, making sure that what they're reporting looks legitimate by the criteria, helping walk them through things that, discrepancies when we find them, work with Karen Lee's folks on data validation for any HAI measure that's reportable. And in addition to that, my program also uses that we monitor the event and rate data for the facilities to target those facilities that could benefit from either some one-on-one reduction activity, or if there's enough facilities, offering a state collaborative to pull everybody together to try to do some, reduction activities on more of a statewide level. We do a lot of education with the facilities. Currently, we have a company that is working with the facilities on how prepared are you for emerging MDROs in your infection prevention and control. And then we will take the information we glean from that work and again, help the facilities out with education to address the gaps that we identify. In addition to Chapter 270, Maine CDC also has the notifiable conditions rule. And this data focuses on, cases that may be more of a public health significance, things that could spread quickly within a facility, outbreaks. Some of the things you're probably familiar with, of course, are influenza and COVID. We've, Legionella, invasive group A strep. And in addition to that, we now have new or emerging multi-drug resistant organisms, and some of these are getting fairly, high on resistance, and their ability to be transmitted between patients is, let's just say, easier nowadays than it used to be. And on that list, we have carbonapentase producing organisms, VRSA, Vanco resistant Staph aureus is still on that list. Candida auris is that's been in the news lately as the fungus in healthcare facilities that's causing, a lot of it, getting a lot of attention. We're also proposing some new multi-drug resistant organisms as VRE, Vanco resistant enterococcus, is being treated with linezolid and daptomycin. We now have dapto and linezolid resistant VRE. So as the drugs of last resort, we're interested in, finding out how much of this are we seeing in Maine and what can we do to slow that resistance down. So we have what has been dubbed containment activities, where if these new emerging multi-drug resistant organisms are identified at a facility, we work with the facility to help identify, is there transmission happening within the facility? And again, trying to stop that transmission. And so, and that notifiable conditions list is available online at Maine CDC and is quite extensive too. So that kind of covers the data reporting and some of how we use it. Happy to take questions.
Rita, just to clarify on the 2 NHSN measures, the C. diff is now being collected and so is available now.
Not available yet because they just started reporting July 1st, which means they don't have data into the system yet.
Okay, and then the UTI is for the future, considering for the future.
Proposed new rule has not gone through all the motions to pass yet.
And Paul, this is Karen Lee. I can provide a little bit of detail around the timing. So my board authorized me to go to proposed rulemaking and earlier this year. So we are tentatively looking at a public hearing on the proposed changes in the month of, I believe, September. And then it is a major substantive rule, which if I didn't say in the beginning, I should have, which again, if you're not familiar with state government, that means my board can provisionally approve the proposed changes after public input. And then they, will consider any of the comments that have been made through that process. Then they provisionally adopt something that then goes to the legislature in January of 2024. And then the legislative committee will determine whether or not they'll take that rule up in their next session. I've worked for state government now for over 11 years, a rule that has never not been taken up. But I suppose they have the ability not to, but assuming that they do, it would then most likely, whatever changes they adopt would go into effect in July of 2024.
Thank you.
Thank you.
Any thoughts, comments, questions on the activities that Maine Health Data Organization and Maine CDC are doing?
Just to also throw out this, because I think having something to do with infection control as a measure is very, very important for us. There is a QRP coming out measuring healthcare associated infections requiring hospitalizations. Right now, they're just to have done the baseline, and it's actually going to be starting October 1st. So that's something that we'd have data to as well. Just throwing that out there.
That's a new CMS requirement, Maureen?
Yeah. Yes.
Rich, I think your comment about criteria for UTIs is interesting. Do you want to explain that to the rest of us?
Sure. So I think a lot of us are aware that the incidence of asymptomatic bacteria or bacteria in the urine is pretty high in nursing homes and does not necessarily account for a true urinary tract infection when you identify bacteria in the urine. If you really look at the McGeer criteria for true signs and symptoms of a UTI and hold people to it, your incidence of getting your analyses will drop significantly, which as a byproduct of that, your positive cultures will drop significantly. We have worked pretty hard on this in our group. It's kind of gotten a little bit by the wayside because of the pandemic, because a lot of staff don't understand the McGeer criteria. The education has gone out the window. So we're still trying to make efforts to educate them on that. But things like the urine is dark or it smells funny are absolutely not indicators. 100% should never be obtained just for that.
Agree.
And I understand that sometimes individuals are fairly impaired and can't reliably report symptoms, and I do get that. But if you really hold facilities more accountable to the McGeer criteria or other specific criteria for UTI, we could dramatically reduce the rates of UTIs because they're not really UTIs.
Yeah, well, I think that's what's important about this conversation, Rich, is that, you know, we're not in these facilities. We don't know what these measures mean, right? So I think it's just really important for you all to provide us feedback with, you know.
But a way that we use the data is to look at that data, what is it telling us, and work with the facilities to do education around what can we do before, you know, as this stuff is starting to unroll, there are steps that could be taken so that we, you know, do you want to increase fluids and you know, nurse-driven protocols and whatnot that can go into effect that is so it never gets to the point where it's counted as a UTI. And that's why we want that more detail on the data, because are we battling symptomatic, asymptomatic, what pathogens are we seeing? You know, is it skin flora? Is it GI bugs? It's very helpful when you're trying to focus the prevention measures for a nursing home.
No, absolutely. I mean, increasing diuretics for heart failure is going to probably increase urinary frequency and incontinence. Hyperglycemia is probably going to cause the same symptoms. And it's so easy to reflexively get a UA. It's like the number one request I have on a daily basis from staff at nursing homes. They're like, oh, this, you know, the urine smells like this, or they look different today. I understand it's important to recognize changes in functional status, but there's so many other things that do it and it's not a urinary tract infection in the absence of symptoms. One other comment too, just you mentioned C. diff. I think a lot of nursing homes utilize Nordex, but that has dropped because of their staffing. Maine Health has changed how they test for C. diff. It's a two-step process now. So they're testing a PCR, and if that's positive, then they'll do a toxin ELISA. So you actually have to have both. You can't just have the positive PCR because they're trying to reduce the number of people that are getting flagged for colonization, which apparently is a real thing and has led to overtreatment as well. So I think most facilities use this, but there are more and more labs that are making their way into Maine because of, I think, just the Nordex in their staffing challenges. So
yeah, and that is a message we've been promoting for several years now with labs, that it should be a two-step process. So that because you have the bacteria that has the capability to produce the toxin doesn't mean it's actually producing the toxin in the moment.
Other thoughts? The other observation, I'll just make this obvious, but I don't think I really understood this, Rita, until you explained it. You're using these measures for pretty short-term public health interventions. If we were to adopt any of them, we'd be using them for longer-term payment or other, you know, questions like that. And so thinking through whether both are appropriate uses.
And Paul, I'll answer that. So one of my rules is Chapter 120, which is our release of data to the public rule. And it's essentially the release of data to authorized users. And the use case that you just described in terms of using it for, you know, sort of quality payment reform, however you want to refer to it, that is an acceptable use within our rule.
That's good to know. Thank you, Karen Lee. Anything else on this? Lots of rich discussion today before we move to wrap up. If not, Lisa has graciously agreed to give us some observations from the discussion today. So Lisa, all yours.
Sure, thanks. And I have to apologize. My neighbor has been working on rebuilding a house for like 12 months now. And every time I talk on a meeting, it seems like a saw is going or something. So if you hear that, sorry. So yeah, first of all, big thank you to everybody on the call, staff and all of the folks from facilities. Clearly a whole lot of work goes into this. And I feel, you know, a bit like, I don't know, carrying coals to Newcastle is quite the right analogy, but certainly appreciate the opportunity to reflect as an observer and a bit of an outsider, because clearly so many of you are much closer to the work. So I just want to acknowledge that and offer my humble observations. I think, you know, it's so important to have discussions like this. It's very clear from the discussion up front. And I think, Lauren, you talked a bit about this in terms of the recommendations that you put forward initially, that the internal group had discussed, but to really be clear about the criteria, that we're using and the framework that the collective process is using to make decisions about making a change as important as this. So clearly, some of the things that I heard were identifying measures that are meaningful to patients and families and recognizing the many challenges of that, whether that's having facilities with many patients with dementia who can't respond directly, or the difference between expectations and experience and how much that influences satisfaction. So, it's almost as though every single thought or concept that we have has its own set of challenges, right? So, but meaningful to patients and family, reflecting quality, and ideally, we didn't talk much about this, but the potential to impact costs or control costs as well, are actionable. We heard that many times, and it's, you can't just get something and what do I do with it? So if the whole point is to improve quality, to have measures that allow for opportunity for action by facilities and staff, and clearly don't add an undue administrative burden, whether it's the number of measures or the ability, the process for reporting, recognizing that facilities already have considerable obligations in terms of quality reporting and just direct care on top of that. I think it's also been really important and apparent through these discussions, and I really appreciate the observations of staff and the very experienced clinicians on the group, the need to recognize the clinical subtleties, whether it's, what was just discussed in terms of UTIs and the associated unintended consequences that come out of so many of these, antipsychotic discussion, there's so many layers to the, what's going on, what we're trying to achieve, and what can inadvertently happen as part of that. So thank you for all of that. And then I think, the last point about the need to recognize the different intended uses of measures and how we're, pulling those measures and what we're intending to do, though ultimately, again, driving improvement in the experience of care in the community. I think it's also been very encouraging to me to hear what's already out there, though, in the vast range, whether it's the CORE-Q. I didn't realize actually that it was already being used by so many facilities in terms of measuring experience of care, or the various, clinical quality or the infection prevention control measures. So the good news, I think, is that this effort will be able to pull from, I did hear a few times, potentially create new, but I'll have to say that gives me hives anytime that's mentioned. Not to rule it out, but it is, as you all know, a whole set of challenges and time frame challenges related to that. But I think there is a whole lot already going on. So it gives me encouragement to think what could be pulled from that vast sea, really, of things that are already being done. So that's my humble observations, Paul, and I'll turn it back to you, or invite others to either respond to that or add their own.
Thank you, Lisa. Any additional closing thoughts here today? All right, well, this continues to be one of the favorite groups for me that I participate in, because the quality of the discussion is so good. Just to give you a little preview, we haven't finalized the agenda yet, but we're tentatively planning the August meeting to be on other quality oversight structures that exist. And those will include, for example, the work that licensing does in the survey process. We're hoping it will include what the Ombudsman does and the role that it plays in Maine. And we're also hoping that it might include what the QIO does. So that's the tentative agenda, assuming we can line up all the people that we want. We have lots and lots of other topics. We haven't forgotten about innovation, technology. Those will come later. So certainly, if you have any suggestions for us for topics, speakers, material that you think should be distributed, let us know. And thank you again for your time today. We really appreciate it. Thanks, everybody.
Thank you.